tricks of teaching and learning robotic surgery. And it's now my thank you. So I think we have to move on. And Artem Goncharov is the next speaker, and he will give a presentation about robotic colorectal surgery learning curve. So please go ahead.
Hello, dear colleagues, dear Marco, Andrew. Can you see my presentation?
Yes, we see.
Is it okay? Yes, okay. Oh, thank you. So let's talk about learning curve in robotic colorectal surgery. We started at the age at 70, and before we perform lab surgery, and the robotic give us much more advantages. Is the camera control, the 3D view, stability, the 7 dimensions articulations of the instruments, and this help to perform operation because the surgeon become a 4th armed 3 robotic arms and camera creature. But we have huge background of laparoscopic surgery, and I need to say a few words about my teacher, Professor Alexandrov. Unfortunately, last week he passed away on a 92 age. He performed in 1994 first laparoscopic colectomy in Moscow, and up to 21st century he performed more than 1,000 laparoscopic colorectal procedures, and this background helped us to move on with the robotics. And interesting fact with Professor Alexandrov that his PhD was the anterior resection of the rectum, where he described double staple technique using Russian staplers 5 years before it was firstly demonstrates in English-speaking journals. So return to Da Vinci. Da Vinci is not so simple technique, a lot of buttons, a lot of switch pedals. So we need to learn it, to perform operation is minimum as good as we perform laparoscopic operation. Da Vinci system has very good options of 2 console proctoring, where the proctor and mentor or with resident can operate together and switch between each other the operative maneuvers. And if we talk about learning curve, usually we think that it's some kind of curve, but it's not so simple. It has some problem. And if we discuss about time of console operative time, usually we see in the literature some numbers about 20, 60 operation. In this paper, the good operative time in total mesorectal excision surgery was only after 83 procedures, and the good quality was after 30 procedures. So we decided to analyze our experience. We took first 200 cases and with more than 100 TME. In these cases, it was one surgeon experience.
Artem, sorry.
So
you can change
yeah.
your slides.
You now slide changes or not?
No, not
Because we no.
Oh, yeah.
Sorry. Not yet. I will repeat this. And now?
Yes.
Is it changes?
Now we can see port replacement.
And now it works.
Is it changed or not? Because I see presentation. I don't. Sorry.
Yes.
I try to close all windows.
Сейчас все хорошо, сейчас переключается.
Okay. So first 200 cases, and the first of all, every surgeon who begin operating robotically is thinking about port placement. Da Vinci Xi system, the port placement is more simpler, but in Da Vinci Si, it's some kind of tricks, maybe problem for some surgeon. We studied the Korean type of docking, for example, in this slide for TME, the French type of docking for one docking operation, and make for Da Vinci Xi our variant of docking with the change in one hand. And we have second type of docking for very tall patient with a high complex splenic flexure with double docking. Double docking. Slide is not changing.
Oh, yes. Now.
Now? Some problem.
Now, okay.
Okay. With double docking. If look, when we analyzed our procedures performed, we divided in two groups. One first step it was first 95 procedures, and the second step, second 100 of procedures. And we see that the first 100 procedures were mostly colon cancer cases, about more than 50, only 20 rectal resection and 10 rectopexies. And we think that it's a good way to become more comfortable, to be more comfortable with the robot, and to start perform more complex procedure, because on the second step of our learning curve, we decreased colon cancer operation and perform mostly rectal resection, and most of rectopexies perform laparoscopically. Sigmoid resection is the good model for robotic learning. I think it's the best first operation. Maybe the second best operation for the first case is the right colectomy, when you don't need CME and maybe intracorporeal anastomosis, for example, for benign cases. Rectopexy is good to learn how to stitch and to work in a deep pelvis and not performing total mesorectal excision. And the last step is the whole total mesorectal excision with splenic flexion mobilization and mobilization of the rectum to the pelvic floor. Interesting was the term of the operative time. We analyzed our only low TME with colorectal anastomosis, 66 operation, and in the first part it was the operative time was lower than in the second part. And what is the reason for it? I analyzed the subgroups, and mostly differences was in the tumor above the dentate line, because in the second part we operate mostly very low tumors after neoadjuvant chemoradiation. So the time of operation was longer in that cases. And we started to perform intersphincteric resection robotically, dividing the spaces between sphincters, and finished operation with the colorectal anastomosis, sometimes with J pouch. So when you move through your learning curve, you can achieve that like in NASA tax load index demonstrates that the robotic is easier and more comfortable for surgeon you compare with the open or lap surgery. The next problem is the new robotic devices, new robotic systems that can be that flows in this year and next year in the market. So every system needs to learn to make it own learning curve. Maybe it's a problem, but I think it's very interesting. And in conclusion, I want to ask to our audience that for the first robotic operation, better patient selection, start with simple cases like sigmoidectomy, splenic flexure. Most complex procedures as TME with splenic flexor mobilization and right CME with intracorporal anastomosis are better to perform after maybe 20 operation. Pay attention to dog quality, especially using the size system. And for me, our learning curve is about 100 colorectal surgery cases. So I think you should think about these numbers when you practice. Thank you. Dear colleagues, if you have a question, I can answer.
Thank you very much for your presentation. First of all, I think we made a similar experience here, and I can completely support your findings and your opinion. My question is, at least in Germany, 100 cases or 150 cases, it's a lot, probably not for Chinese hospitals, but how do you think you manage in the future to educate and teach residents or new surgeons? Do you think they need the same number of procedures, or do you think if they first are at the table for 30 or 40 cases, does it make easier then to change to the console and become the console surgeon?
Thank you. I think it's very individual for each surgeon, each person, learning curve. And I think that the number of cases will be the same as my experience. because only after 20 cases you begin to operate properly, not to make mistakes between robotic arms or so on. And you feel comfortable with the robotic surgery only, I think, after 100 cases, and you perform operation quicker and easy and perform very complex cases. I didn't see any problems with the first 100 cases compared with second 100. The same rate of complication. We have 1.5% of performing of conversion to the open procedure in first and second, but I think we we do this more slighter, more easier for us because the patient selection. Because if we will start with a complex TME, I think it will be it should be problem with the conversion or something like that, and more rate of complications.
Artem, I have a question. I have seen your experience when you easily move from SI to XI system, but different robotic system have different logic. And do you have experience to use different robotics system, and how it's difficult to shift from one system to other system?
Thank you, Andrew. I have experience of performing few operations on XI. Mostly it's SI system, and I try some part of operation on transcenteric Senhan system. I think for a surgeon who operates on SI, XI is a very good development of his skills and of his surgeon practice, because XI is completely better and easier for operation, and some changing in the docking practice, but everything is good and better, and so you have only advantages. In the other type of robotic systems can be problem, because they are not on maybe good, not well developed in that time. So you this systems, I think, is not so good for the present day. Maybe in some future, but other systems now it's a problem. So
I see. It's, do you mean that every platform for robotic surgeon will need special training?
yes, of course.
Mm-hmm.
I think it's easier for a robotic surgeon to change platform, but the platform which we can see, like Transcenterix and CMR, Oxford robot, it's a different type, and you need to rethink docking practice and some working process.
And go ahead. And next presentation from Nanjing, China, single port robotic surgery, present and future. Professor Jan, go.